So I'm fellowship trained in movement disorders, and what that mainly is Parkinson's disease. We do see other things like tremor and Huntington's disease, dystonias, but the majority of what we see is Parkinson's disease, really. So before I get started, I just wanted to kind of get a show of hands of the different types of professions that we have in the audience here, so I know who I'm talking to. How many of you are physicians? Okay. And nurses? Okay. And do we have any physical therapists, speech therapists? Okay, great, great. And what else am I forgetting out there? Social worker, okay. Anything else?
General public.
What was that?
The general public.
Okay, general public, that's great. All right, great. Okay, well, hopefully this will be helpful for all of you guys and shed some light on some of the things that we see more in Parkinson's disease now, or deal with more than what we used to just contain Parkinson's disease to. So upon completion of this lecture, you should have a better understanding of the non-motor symptoms of Parkinson's disease, the importance of treating them, and their effect on the quality of life of our patients. I also have no disclosures or conflicts of interest. All right, so this is what our typical Parkinson's patient looks like, and most of you can probably recognize this as being Parkinson's disease. This is the classic, this person's showing the classic symptoms of Parkinson's disease, the tremor, kind of a stooped gait, shuffling gait, bradykinesia. But we know that now that there are so many other symptoms in Parkinson's disease than just the motor symptoms. And they really have gone somewhat under-recognized and under-treated for a long time, and they're really the new focus in this area. And they dominate the majority of our patient visits. These are the symptoms that we're talking about. The tremor takes 5 minutes or whatever it takes, but the non-motor symptoms are what cause the biggest problems in their quality of life. And unfortunately, they can be the most difficult to treat. A lot of our Parkinson's medications that help the motor symptoms don't treat any of the non-motor symptoms, and the surgical treatments like DBS also do not, a lot of times, touch the non-motor symptoms, which is unfortunate. So first, one of the first things to have been recognized about our Parkinson's patients was that there may actually be a Parkinson's disease personality type. So they can have a more cautious personality. They can be really orderly, reliable. I have a number of engineers who get DBS and become really overly obsessed with changing settings. They can be statistically less likely to smoke, use alcohol, drink. And actually, there is some theory that maybe nicotine is preventative in developing Parkinson's disease. Those studies are still going on, but there is that theory out there. So we think that maybe this is due to the decreased dopamine levels prior to actually being able to see the motor dysfunction in this disease. So we know that actually about 70% of the dopamine neurons are lost prior to a clinical presentation of of Parkinson's disease. So we know it's more than just the shakes now. It's a lot more than that. It encompasses pretty much every system of the body. So they're usually mediated by non-dopaminergic pathways. And some of the other pathways that are affected are the cholinergic pathways. And they're affected in a greater degree in patients with dementia. And we see these pathways affected more in Alzheimer's disease than in Parkinson's disease dementia. But the cholinergic pathways are a major one that's affected. Serotonergic pathways and the noradrenergic pathways are also affected. The noradrenergic pathways of the limbic system are associated with cognitive and neurobehavioral problems, including dementia, depression, anxiety, and attention deficits, all of which we do see in our Parkinson's patients. So these areas are a huge target now for new drugs, new research. So we're going after some of the other pathways in the brain. So we're going to do some patient presentations just to give you an idea of maybe what we see in the office and what you might see out there as well. So here's a 63-year-old. He presents to the primary care physician's office with decreased smell and constipation. Seems relatively simple, probably not too complex. But then 2 years later, he has begun acting out his dreams, and his wife is in the office with him complaining that she's getting hit and kicked while she's sleeping, and wondering what we can do about that and what's going on. So anosmia, it can be a prodromal symptom present up to 20 years prior to clinical diagnosis of Parkinson's disease. Patients will oftentimes not even really mention that they've lost their smell. This person noticed it, but a lot of times after the diagnosis, you'll ask them about it and they'll say, yeah, you know what, that's true. And everybody else can smell these flowers. I can never smell them, or they'll make some association with it. So it's oftentimes present there for a long period of time before the clinical diagnosis is made. There's no treatment that we have for this, and it can be a problem with quality of life for these patients because it causes some decreased appetite. I mean, if you're not smelling very well, you're not tasting your food very well, a lot of people just don't want to eat. And of course, we want to make sure that they're maintaining their weight and not losing weight. So it is important to discuss that. Constipation, this is a major issue, and we do spend a lot of time talking about this. And it's really, the gut has kind of become a big area of research in Parkinson's disease, and I'll talk a little bit more about that. But there are a number of mechanisms that we think may be going on with the constipation in Parkinson's disease. So there's actually a degeneration of the neurons in the gut, potential presence of Lewy bodies there, which are the protein that we actually see in the brain that contributes to some of the symptoms of Parkinson's disease. There's weakness and incoordination of the muscles, of the pelvic floor and the abdominal muscles, improper functioning of the autonomic nervous system, which is responsible for regulating the smooth muscle activity. There can be, in all Parkinson's patients, we can see dystonia of any muscle group. Usually it's a hand or a foot, but there's some thought that maybe there's a dystonic contractions of the gut and the muscles in the gut. And then in older patients, if it becomes difficult to have a bowel movement, they'll sometimes just resist the urge to do so, just worsening the constipation. So this has been a big area of study recently, and there was a Danish study that implicates the vagus nerve as possibly a transport mechanism of Parkinson's disease from the gut to the brain. So they early and complete severing of the vagus nerve cut the incidence of Parkinson's disease in half as compared to the general population, and partial severing resulted in the same number of cases of Parkinson's disease. I think this study almost brought up more questions than it answered, but there are people looking into this now about why would it start in the gut? How does it start in the gut? Is it an infectious process? Is it a toxic process? There's some thought maybe it's a prion process. There may be some increased permeability of the gut in Parkinson's disease patients that leads to some sort of infection being able to get in and travel up the vagus nerve. And then what's the trigger for the spread? Why would it just all of a sudden spread up the vagus nerve? We don't know. So those are some areas of research that are going on right now that may be able to help us in the future. So the constipation is also a prodromal symptom. It can be present years in advance of the clinical diagnosis of Parkinson's disease. The treatments, try to start conservatively with dietary changes. A lot of times that helps early on, increasing fluids. The majority of patients, I think, people out there don't drink enough fluids, and so that's a way to help with that. Stopping other constipating medications, not just Parkinson's medications, but we've all seen patients with a list of 50 medications or something, and some of them are definitely needed, some of them probably aren't, and we can cut those out if possible. Exercise, which we encourage anyway in our patients, because it has been shown to be the one neuroprotective thing that they can do for themselves, but it will also help with the constipation. Stool softeners, they help plus or minus. Miralax is one of the most helpful, and a lot of people just require it daily. It's not recommended to take that way, but in this patient population, they almost require it daily. Lactulose, and then we can always turn to our GI friends for some help, which definitely I have had some patients that have such refractory constipation that we have to go that route. So our patient also had started acting out his dreams at night, And this is called REM behavior sleep disorder. It's a sleep disorder that's specific to neurodegenerative diseases. And it's a parasomnia that's characterized by lack of muscle paralysis during REM sleep. So the part of your brain that's supposed to shut down your muscles at night when you sleep so you don't act out your dreams isn't working. It's not shutting down those muscles. So you're out there, running, catch the dog, or saving. I've had patients say, oh, no, I was just saving my wife from the robber or something. So it can be very disruptive, though. It's a really complicated mechanism, not fully understood, but we think that it's a dysregulation of multiple brainstem nuclei that's leading to the lack of atonia. So it's important to treat because it can affect the sleep quality and can be dangerous for both the patient and the bed partner. Up to 75% of patients who present with REM behavior sleep disorder will go on to develop a clinical case of Parkinson's disease. So if you see that and the patient doesn't have any other Parkinsonian symptoms, it's important to monitor them clinically. You'll probably see some motor symptoms of Parkinson's disease in the next few years. So these are just some of the other, they're a little bit more rare, but some of the other neurodegenerative diseases that we can see REM behavior sleep disorder in. So statistically, Parkinson's is going to be the most common, but some of these other ones, some of our frontotemporal dementias, the prion-apathies, or tauopathies. So we can definitely see it in this population as well, but Parkinson's statistically will be the most common. So the treatment, the best treatment is clonazepam at bedtime, and usually we don't find too much tolerance or abuse in this patient population when you're treating them for the REM behavior sleep disorder. We do have to be a little bit careful in our more elderly population. We don't want to create more falls or confusion in the middle of the night and more cognitive problems. So if somebody's already hallucinating or having a lot of cognitive problems, clonazepam is maybe not the best. Melatonin can sometimes help with it, can be used alone or in conjunction with clonazepam. Other drugs that are reported to help but may not have such good effect, Mirapex, Aricept, Levodopa, which a lot of these patients are already on, some of the anti-epileptics like Tegretol, and then two of our antipsychotics, Clozaril and Seroquel. Seroquel is the most used in Parkinson's disease, and again, if the patient is hallucinating and has a lot of cognitive problems, that might be a better choice than the clonazepam. So another patient, we have a 65-year-old man with Parkinson's disease. He was diagnosed about 5 years ago, presents to your clinic with relatively well-controlled symptoms. He's on ropinirole, 8 milligrams 3 times a day, which is a good dose of that. It's one of our dopamine agonists. A lot of our younger patients are started on dopamine agonists prior to levodopa. And that's mainly to help reduce the risk of dyskinesias later on. The longer they're on levodopa, the more likely it is they'll develop dyskinesia, or these kind of dancing-like movements. So starting with the dopamine agonist helps to reduce that. So he's kind of quiet. He says he's doing pretty well, doesn't say too much. But at his next appointment, his wife comes in with him and mentions that he's been gambling a lot more. He lost $10,000 in the last month. And then upon further questioning, patient admits to also that he's been getting up at night, gambling online, and has lost more money than what his wife actually thinks. So unfortunately for these patients, we are close to a lot of centers for gambling, Las Vegas, and we have Chumash. It's not the best. So ropinirole, or dopamine agonists, are implicated in impulse control disorders. These are, we want to say they're rare, but they're actually not as rare as you'd think when you really start kind of picking up asking the right questions about this. So it's defined as a failure to resist impulse, drive, or temptation to perform an act that is harmful to the person or to others. It can be also accompanied with depressed mood, disinhibition, irritability, appetite disturbances, and it can come in a lot of different forms. I think the most common is gambling. We see shopping, hypersexuality, eating compulsions. They don't necessarily have to be what we consider bad behaviors. I had a patient who was obsessively going to church. So she would go to church like 5 or 6 times a day. And so we wouldn't necessarily consider that a bad behavior, but it was actually bothersome and bad for her lifestyle. It was hard on her husband because he was having to drive her, and so it was something that we had to do something about. But so it doesn't have to be one of these, what we classify as a bad behavior, but oftentimes it does fall into these categories. So the patients who are at risk, patients with a personal or family history of obsessive compulsive disorder, patients who do have an impulsive personality, which is somewhat rare, again, in the Parkinson's personality type, but you can see it. And patients who have a history of alcoholism, drug addiction, smoking, or other addictive behaviors, those are going to be prime candidates for this problem. So it's an interesting mechanism that I don't think we fully understand, but the dopamine agonists actually bind more to the D3 receptors. So usually we're treating our levodopas and like our carbidopa-levodopas or Sinemet. It binds mainly to the D1 and D2 receptors, which treat the motor symptoms. The D3 receptors are more implicated in the addiction process, and this is where our dopamine agonists bind. So they have a greater affinity for these receptors, and we think that that plays a role in why that they're causing this type of behavior. And actually why they don't induce dyskinesia. So the D1 and D2 receptors are more implicated in dyskinesia, and the D3 receptors less so. So the dopamine agonists are pramipexole or Mirapex, ropinirole or Recrip, and rotigotine or Nupro. And they can be seen with higher doses of carbidopa-levodopa, but it's really less common and not as severe usually. Can also be worsened with DBS, or deep brain stimulation, which is a surgical procedure that sometimes is done for Parkinson's disease. And that depends on the target. Usually the subthalamic nucleus, we see it more than with the globus pallidus internus. And those are the two different targets that are used in Parkinson's disease for DBS. And it does go under recognized. I think the FDA hasn't added the black box warning, but they were talking about adding a black box warning to these drugs about the impulse control disorders, because they can be so severe and affect quality of life so much in these patients. So what do we do about it? You got to stop the dopamine agonists. The patients will oftentimes not want to do that. They'll fight you on it, but it has to be done because they can lose everything. All right, so continuing on, he's taken off his ropinirole and his gambling stops. His motor symptoms are well controlled on his Sinemet 25100, 2 tablets, 4 times a day for about 3 years. It's a pretty good dose, on the lower side, but pretty good. As his motor symptoms progress and his Sinemet doses increase, his dyskinesia also increased. So he's starting to get more movement, head movement, trunk movement, arm movement. He also begins to have some dizziness with standing and some near syncopal episodes multiple times a week. So this happens a lot when people are getting out of bed, some dizziness because they stand up too quickly. And we see the orthostatic hypotension presenting in a lot of our Parkinson's patients. Most people have it to at least a small degree. If you take their blood pressure sitting and standing at every appointment, you'll see some changes. And then we have a subset of patients who have it really severely and can barely stand up. So we know that there is cardiac and extracardiac sympathetic and noradrenergic denervation and a baroreflex failure. So that's been seen in all of our Parkinson's patients with orthostatic hypotension. And then cardiac sympathetic denervation has been confirmed histopathologically in these patients as well. So if you see it early on in the disease, if it's there when you diagnose them with Parkinson's and they haven't had too many clinical symptoms for that long, you want to consider other Parkinsonian syndromes like multiple systems atrophy. If it comes on later in the disease, they've had the disease 5-10 years, it's more likely associated with Parkinson's disease. So conservative treatments, we try to, again, increase fluids, compression stockings, increase salt intake if possible, and stop any antihypertensives. Sometimes we need to boost the blood pressure, midodrine, fludrocortisone. There's a drug that came out in the last couple years called droxidopa or Northera, which is specifically approved for this indication, orthostatic hypotension in Parkinson's disease. It was actually only approved for a 2-week period of use, but it can be used longer than that if needed. And unfortunately, we can see such fluctuations in blood pressure. We can see a supine hypertension, and then orthostatic hypotension. So sometimes a short-acting antihypertensive at night is needed, and then one like mitogen or fludrocortisone is needed during the day, stopping the dose in the early afternoon to prevent these blood pressure increases at night. So it can get a little bit complicated. A lot of times we'll work with a cardiologist in order to figure out, the dosing of the medications and which medications to be using. We have a little bit of an older gentleman here, 80-year-old man with a history of Parkinson's disease, diagnosed 15 years ago. And he comes in for his follow-up. He has been having some hallucinations and has been fearful that his wife is having an affair with one of their friends. He has angry outbursts and confusion late in the afternoon and early evening. And in the office, he's friendly, but he doesn't provide much of the history. His wife provides most of the history. Very typical presentation for somebody who's had the disease for a long time and is starting to develop Parkinson's disease dementia. So up to about 75% of patients with Parkinson's disease will actually develop some sort of dementia related to the Parkinson's disease. And then the other 25%, at least half, will experience some cognitive problems associated with Parkinson's disease. I think it's actually probably more than that. The studies, they range, it's a huge range, from like 20% to 95% when you read the literature. So I think it's actually a little bit more than 25, or about 12.5% that experience cognitive problems. The most common difficulties that we see are in Parkinson's disease dementia, executive functioning impairment, so they're having a hard time planning and working memory is difficult, visual spatial deficits, attentional deficits, and then language dysfunctions. So the tip of the tongue phenomenon, they're just expressive difficulties, which is, I think, one of the earliest and most common complaints that I hear about. So even in people who who haven't developed dementia, the expressive difficulties are one of the most common that we hear about. So it's associated with a diffuse Lewy body pathology. We can see on autopsy there can also be some typical Alzheimer's pathology as well. But if somebody is diagnosed with Parkinson's, we assume that it's more Lewy body pathology clinically than Alzheimer's disease pathology. And again, neuropsych testing can actually help us to determine where they're having the most difficulties. And if it looks more like a Parkinson's disease dementia, we see that on neuropsych testing versus Alzheimer's dementia. They're different patterns of deficits. So the risk factors for developing Parkinson's disease dementia: increasing age, increased severity with longer duration of Parkinson's disease, and early hallucinations. So if they start hallucinating early in the disease process, you want to watch those patients. Some say that early onset REM behavior sleep disorder can be a worse prognosis for developing dementia earlier on in the disease as well. So this is just a picture of the Lewy body, so that's what it looks like pathologically speaking. And this is just a progression. You can see that early on in the disease, there's Lewy bodies that are limited to kind of the subcortical area, and as the disease progresses, they spread out to the cortical area and other areas of the brain, affecting all these other pathways and creating the dementia. So our treatments, unfortunately we don't have any magic memory pills, and I don't even know if we can, I guess they're somewhat symptomatic treatments. We don't see a huge improvement, but you can see a plateauing of symptoms a lot of times. So Aricept, Exelon, Trazodone, and Amenda, the same drugs that are used in our Alzheimer's patients, are used to help treat these dementias as well. So psychosis and hallucinations, this may not be exactly what patients complain of, but they definitely see very vivid imagery. They'll come in and say, it was animals running across my room, or a lot of times little children or family members who have passed away. And they can be frightening or amusing. And the amusing ones are better, obviously, than the frightening ones. So it can be present in conjunction with other dementia symptoms. Early hallucinations is a risk factor for developing dementia, like I mentioned before. And if it's present before any motor symptoms, if the hallucinations and cognitive problems are present before any motor symptoms, then we'll classify that as a dementia with Lewy bodies versus Parkinson's disease. And they'll later on develop Parkinsonian symptoms as well. So unfortunately, the psychosis and hallucinations can be worsened by the dopaminergic medications that are used to treat motor symptoms. So it becomes a little bit of a balancing act with some of those medications. We typically use Seroquel, although the literature out there for this is not great. There's not much evidence that supports the use of Seroquel. It's unfortunately one of the only ones we can really use. A lot of the other antipsychotics affect the D1 and D2 receptors and can worsen Parkinsonian symptoms. So we do use a lot of Seroquel. Anecdotally, I mean, I do see improvement, but in large-scale studies, it's been somewhat questionable. The Clozaril is the only drug that's actually been shown to have improvement in psychosis and Parkinson's disease, but it's really difficult. It's restricted distribution in the United States. You have to be a certified prescriber, and the patient has to come in weekly for blood tests for the first, I think, 3 months or so, which becomes very difficult, obviously, with a patient who's disabled or hallucinating. So a lot of people just choose not to do that. There's just approved, like in the last month by the FDA, is Nuplazid. And this medication actually doesn't affect any of the dopamine receptors at all. So it only works on the serotonergic system and was specifically designed for Parkinson's patients with hallucinations. So it's not on the market yet, but we're hoping to see it and see how it works. So we want to avoid our typical antipsychotics like Haldol especially. Not a good medication for our Parkinson's patients. It'll worsen their Parkinsonism. Zyprexa has some affinity for the D2 receptors, so we want to be careful with Zyprexa. Risperdal, it can be used in low doses, but I tend to avoid it unless we've exhausted every other possible drug out there. And Geodon, same thing. Those ones all have, all like the D1 and D2 receptors, so we got to be careful of those. All right, so a few months later at follow-up, the patient's wife notes that he's having to get up at least 5 times every night to urinate, and this is bothersome because the patient has difficulty going back to sleep, and then he'll walk around the house, get confused, and we definitely don't want him in the kitchen, trying to cook or other things. So urinary dysfunction is something that is a major problem and can be a complicated picture and multifactorial in our geriatric population for both men and women. So our normal urinary storage is dependent on our sacral autonomic reflex, and the micturition reflex is under the influence of dopamine and GABA. So these reflexes are affected in our patient population. So depending on the patient's age and cognitive status, some of the medications that are used to treat this problem have unfortunate and unwanted side effects. So they have the anticholinergic side effects, can worsen cognition, confusion. So oxybutynin and Vesicare, those drugs can sometimes be problematic. Some of the patients are maintained pretty well on them, and if they're doing all right, then I'll tend to just leave it. But if they start having cognitive problems, it's something to look at. There's a newer drug out called Myrbetriq, which works very well and only works on adrenergic receptors to relax the bladder smooth muscle, so it doesn't have any cholinergic effects. And this drug has been helpful for a lot of patients. Unfortunately, because it is new, it's very expensive, and insurance companies require you to run through oxybutynin and Vesicare and some of these other ones sometimes first in order to get approval for Myrbetriq. Sometimes you can override that, telling them they have cognitive problems or something, but a lot of times you still have to get the approval process through. All right, so we have a 76-year-old female with a 5-year history of Parkinson's disease, and she presents with the sleep onset insomnia. So she's having trouble falling asleep at night. She only sleeps about 3 to 4 hours a night, and it's been getting worse over the last 3 to 6 months, and her mood is worsening because of this. She also thinks her tremors worsen, and she tried some over-the-counter melatonin, which she said just didn't help. So sleep disturbances are one of the non-motor symptoms that we do spend a lot of time on, and they're reported in about 90 to 95% of Parkinson's patients. So different sleep disturbances, but they are reported in almost everybody. Dopamine plays a role in our arousal, our wakefulness, and our sleep through the ventral tegmental area, through our D2 receptors. The ventral tegmental area communicates with the mesocortical and mesolimbic regions, which are associated with arousal. So it's a complicated mechanism, but dopamine and the D2 receptors are important in that. A D2 knockout study showed that these two receptors were needed for the maintenance of wakefulness in mice. So if we take those out, then we're going to see daytime sleepiness and things like that, which we do see in a lot of our patients. So this is what I hear a lot. My patients stay awake. You're looking at the clock, it's 11 o'clock, it's 12 o'clock, it's 1 o'clock, it's 2 o'clock, and finally get to sleep at 3 or 4 in the morning. So insomnia is one of the most typical. We have sleep onset insomnia and sleep maintenance insomnia. So sleep onset insomnia is trouble falling asleep at the beginning of the night. Sleep maintenance insomnia is trouble staying asleep. So you're waking up at 2 and then can't get back to sleep, and then you wake up at 4 and can't get back to sleep. In our Parkinson's patients, we want to avoid our typical sleep aids like Ambien, Lunesta, Sonata. Those can cause just weird behavior in these patient populations. Ambien especially can do it in somebody who doesn't have Parkinson's disease, so I've seen some strange things on that. So I typically do not use those. Melatonin can be tried. I think, in all honesty, it's not that effective for this patient population, but some people get some effect from it. There are a lot of people out there who don't want to take anything for sleep, and if that's the case, sometimes guiding them to some sleep meditation practices or mindfulness techniques can help and avoid medication for some time. Typical medications we'll start with or try for this patient population: Remeron, Trazodone, a combination of melatonin in one of these. And then if there's a lot of dementia or hallucinations present, then Seroquel can also help with sleep. You will get some pushback if the patient's on Azilect as well about some of these drugs, about potential serotonin syndrome, which is really very low risk, but sometimes you'll get a call back from the pharmacist about that. And sometimes a dopamine agonist can cause a lot of sleepiness, so if they're really having a hard time going to sleep, you could dose the dopamine agonist a little bit closer to bedtime and see if that helps as well. So excessive daytime sleepiness and fatigue, we hear this a lot. So you want to rule out obstructive sleep apnea. Parkinson's patients can get it just like the general population and are probably at a little bit higher risk, so rule that out, of course. Is it medication related? Not necessarily just Parkinson's disease medications, but again, we have so much polypharmacy a lot of times that we forget what some of the side effects are of some of the medications or haven't looked at it, and maybe there's something that we can reduce there. So the dopamine agonists, again, they can cause severe daytime sleepiness. They actually can cause sleep attacks, rarely, but they can cause that. Is it related to their off time with their Parkinson's medications? So if they're having a lot of on and off fluctuations during the day with their Parkinson's medications, then a lot of times the off time, people experience fatigue. They'll describe it as fatigue or heaviness, and it's important to ask them, maybe you can keep a diary of when the fatigue's coming on and versus when you took your last dose of Sinemet, and see if there's a correlation there. Is it related to depression? So a lot of times it'll be less sleepiness, but more just constant fatigue in really depressed patients. You can use stimulants, but we want to be careful and weigh the risks and benefits. There's some reports of Ritalin potentially helping with freezing of gait in our Parkinson's patients as well. So low-dose Ritalin can sometimes be helpful, like 5 milligrams once or twice a day can sometimes be helpful and can help with freezing of gait sometimes. So vivid dreaming, these lobsters are having some vivid dreams, smelling some butter, and they're waking up terrified. So vivid dreaming is very, very, very common. Patients who have hallucinations and have more vivid dreaming are at a higher risk for dementia. And then also, our REM behavior sleep disorder patients have very vivid dreams, and those are the dreams that they're acting out. Again, low-dose Seroquel can be helpful, and some of the medications that are used to treat motor symptoms can be changed as well. Sometimes dosing levodopa at bedtime increases vivid dreaming for some patients. So it's always worth looking at whether they need that bedtime dose or not. All right, so our patient, we placed her on Trazodone, 100 milligrams, which is a pretty good dose at bedtime, and she began sleeping a little bit longer. She thinks her mood's improved, but still feeling somewhat depressed on a daily basis. And she also begins to notice some tingling at times throughout the day, which is sometimes really painful, and it fluctuates from day to day. It's not constant. She has good days and bad days. So we have our anxiety and depression and pain are all symptoms that we see more in our Parkinson's patients. So we can see a generalized anxiety type picture, social phobias, panic disorders, and the risk factors in Parkinson's disease for developing anxiety disorders are being female, more motor fluctuations, and a history of a previous anxiety disorder. So keep in mind that sometimes with anxiety, it can be related to, again, the wearing off of their medications. So they don't communicate that very well, but a lot of times if you have them keep a diary exactly of when they're taking the medications versus when these symptoms are coming on, you'll find that the anxiety is coming on towards the end of the period where they're going to be taking their next dose. And if you can even out their fluctuations a little bit more, a lot of times the anxiety will even out as well, or at least will be a little bit better controlled. We try not to do long-term use of benzodiazepine. SSRIs can be helpful in this patient population. And again, optimizing the levodopa therapy to reduce the fluctuations can be really helpful. A lot of people, especially in this area where I train not so much, people didn't care so much about taking medications, but out here a lot of people have don't want to take medications, which is fine. But then you need to be aggressive about getting them into psychotherapy or meditation, mindfulness techniques, yoga, those types of things to really help reduce anxiety. But I do get pretty aggressive about referring them on to some sort of psychotherapy or something if they don't want to take medication or if we're having a hard time with controlling anxiety. You'll see that their motor symptoms are much worse if you don't control anxiety and depression. So they'll have more tremor. They'll have a harder time moving. They won't walk as well. So it is important to treat those symptoms. So depression, anxiety and depression are almost two sides of the same coin. We'll see more depression in some people, more anxiety in other people. And again, it's involving all these other non-dopaminergic pathways that we didn't think were affected in Parkinson's disease, but we now know that they are. So we do see depression in PD population more than the general population. And we know that it's actually more than just them having to deal with a chronic disease. It's because of these actual chemical changes in the brain. And predominantly, their type of depression is characterized by apathy. So it's really just, patients, family members, and friends will describe them as being just not wanting to do anything, apathetic, just really apathetic. There's a lack of energy, a lot of psychomotor slowing, obviously, irritability, and we see a little bit less guilt in this population with their depression than other patients without Parkinson's disease. So apathy there was actually, at the last Movement Disorders Conference, I think there were like 5 or 6 talks on apathy and what we can do for apathy in this population. They do tend to respond to SSRIs. Again, if they're on Azilect, you're going to get some kickback from the pharmacy about that, but it is a really low risk, and in fact, I don't think there's actually been a case reported of serotonin syndrome with Azilect and an SSRI. So it's usually safe to use. You want to optimize their motor symptoms best you can. Psychotherapy, exercise, which we talk about, I think, at every visit now with our patients for the neuroprotective effects, but also to help some of these other non-motor symptoms. And then meditation and mindfulness, again, get a lot of pushback from patients who don't want to be on medication, more medication. So you can try more conservative approaches, but I do tell them that if it's not responding to that, then we need to get more aggressive about treatment of the depression. So pain is something that's often almost overlooked in Parkinson's disease or not even related to Parkinson's disease. And sometimes it is related and sometimes it's not. And it can be a little bit difficult to distinguish. So it can be seen with the motor fluctuations. Again, if they're getting closer to the end of their dose, towards the next dose, and the pain's coming on, they're getting tingling, they're getting pain. It's described all different kinds of ways, but if it's coming on at the end of their dose, then it's probably related to their medication. Dystonia, we can see dystonia, which they won't necessarily identify as that, but tightness of muscles, curling of the hand, curling of the foot, curling of the toes. And that often is medication related. You can use Botox injections sometimes for the dystonia, which can help if it's not responding to medications. So if the pain does respond to the levodopa, so if they take their next dose and the pain gets better, it's likely Parkinson's disease related. If it responds to anti-inflammatories or other pain medications, it's probably not Parkinson's disease related. It's probably more non-PD musculoskeletal etiology. And we can work with primary care doctors or orthopedists to figure out what's going on. I mean, of course, our patient population is on the older side, so pretty much everybody's going to have some sort of arthritic process going on. And so, unfortunately, having Parkinson's disease doesn't exclude them from that. Depression will worsen pain just as it does in the general population. And you can consider using Cymbalta or gabapentin, which helps to treat depression and this kind of neuropathic pain if needed. We have a 79-year-old man with a 12-year history of Parkinson's disease. His main complaints revolve around the difficulty of being heard in conversations and on the phone. He's having a hard time. He can't make phone calls anymore. His friends can't hear him. And his wife mentions that he coughs a lot when he eats. So speech disturbances is, again, pretty much everybody's affected by this to varying degrees. Hypophonia is the main thing that we see. The mechanism is really variable and inefficient movements of the chest wall. It responds to a specific type of speech therapy, usually called Lee Silverman voice training, but it's not a definite fix for that. That requires the patient to be aware of it and to be doing the certain things that they learn in speech therapy in order to combat that on a daily basis. Very limited response to levodopa or other surgical therapies that we use for Parkinson's disease, and it can actually be made worse by deep brain stimulation sometimes, depending on the programming and the location of the lead that was implanted. Again, usually the subthalamic nucleus, we see speech deficits worse than in the globus pallidus internus target. We can see severe dysarthria, which can be seen later in the disease. And it's a rapid speech that's perceived by the listener. So they sound like they're talking really, really fast, and it can be very difficult to understand them at times. We can see dysphasia, which is usually in conjunction with the speech disturbances. You don't usually see just isolated dysphagia. And if it's due to the inefficient motions of the tongue back and forth prior to actually being able to get the food bolus to move into the pharyngeal phase. So also there can be xerostomia reported by some patients, which can worsen the dysphagia. This can sometimes be med-related, Parkinson's disease or non-Parkinson's disease medication-related, but there's actually a reduced production of saliva in Parkinson's disease. Patients will complain of increased saliva or drooling sometimes, and that's actually not due to an increased production of saliva, it's actually due to a decreased swallow rate. So sometimes just getting them to chew gum or suck on a hard candy is enough to reduce the drooling throughout the day for them because it keeps them swallowing. So we can also do mild block injections into the glands, the parotid glands, to help reduce the drooling if it's really severe. And usually I won't do that unless the patient's really having puddles of drool during the day or it's keeping them from going out, just because you can dry them up quite a bit, and then you have another problem on your hands if you dry them up too much. I went over a lot of the non-motor symptoms. I mean, each of these topics can probably have their own whole talk, but it's important to know that Parkinson's disease involves much more than just the motor symptoms associated with loss of dopamine neurons. Complex pictures, these patients are not easy. They take a lot of time and may require frequent visits or long visits to address a lot of these issues. And keep in mind that if the non-motor symptoms aren't addressed, the motor symptoms will be much, much harder to address as well. So we got to address them all in conjunction with one another. I'm sure everybody has places to be, so. All right, thank you. Thanks for having me.